uh, last week's webinar, and I want to say from the start that a couple of those things are still in process. So I want to go through that real quickly before we get too far down the path and get a lot of questions in the Q&A box about them. So we had some questions about zip code level data, and I was hoping to have some additional guidance to share with you today. I do not have that yet. That's still in process, and we will provide an update on that progress on next week's webinar. Also, colleges and university guidance. We're reaching out to the Board of Regents to try and start those discussions. I don't have much to update you on yet, but just know those processes are ongoing. Reoccurring illness, we're still watching everything that's being discussed nationally and at a global level as far as like reoccurring illness, and so I don't have a lot of updates for you on that today, but I do have quite a few updates on other things that were included on your list, and so I want to go ahead and just kind of jump into the meat of the discussion. One thing I want to say from the start is, if you have questions and want to submit those, please do so, but please use the Q&A box, not the chat box. I cannot access any chats that are sent directly to the host, and so please again use the Q&A box, and we would encourage you to submit questions. So as always, this webinar is going to be taped and archived and made available for later viewing. So one of the requests we got last week, and one of the issues we've been working on for the last week plus, is the issue of multi-system inflammatory syndrome in children, and this is associated with COVID-19 infection. So I want to take a few minutes and just kind of walk through what we know about this situation and what we don't know, quite honestly. So late April, there were clinicians in the United Kingdom that did recognize increased reports of kids with Kawasaki-like syndrome and who had recently been infected with COVID-19. And I'll talk about Kawasaki-like syndrome here in the next slide, but those reports from the UK described 8 cases, and that included 1 death. 75% of those patients were Afro-Caribbean descent, and 62.5% were in males. There have also been reports from New York City and New York State. They've identified about 102 patients with a similar presentation who've tested positive for COVID-19, and they're really in the process of doing a more thorough study and doing medical chart abstraction to really understand how many of those children truly kind of meet the multi-system inflammatory syndrome case definition, and we'll also talk about that case definition here in a minute. So when we've said to people that this MIS seems to be Kawasaki-like, we've gotten a lot of questions related to, well, what is Kawasaki? It's not really a disease that we talk about that often on the public health side, so I wanted to just take a minute, take a step back, talk about Kawasaki disease, knowing that that's what we're talking about. What we're seeing with COVID-19 is not Kawasaki, but I think it lays a framework for people to kind of understand. So Kawasaki disease is an acute febrile illness of unknown cause. It's thought to be related to viral infection. It was first described in Japan in 1967, and the first cases outside of Japan were reported in the state of Hawaii. So clinical symptoms include fever, rash, swelling of hands and feet, irritation and redness of the whites of the eyes, swollen lymph nodes, especially in the neck, irritation and inflammation. It is the leading cause of acquired heart disease in the US. And so one of the serious complications of Kawasaki disease is coronary artery dilatation, and it can cause aneurysms. And so there's not a specific test for Kawasaki's disease. It's a clinical diagnosis based on the symptoms and physical findings. Usually it's treated with IV immunoglobulin and aspirin. So again, what we're talking about here, the multi-system inflammatory syndrome in children associated with COVID-19, is a Kawasaki-like syndrome. It's not Kawasaki, but it's a similar syndrome. And what we're seeing is a significant systemic inflammatory response. These patients have a persistent fever, and then they have a mix of the following symptoms that are included on the slide. So hypotension, multi-organ involvement, so that could include cardiac, GI, renal, blood, skin, neural involvement, and an elevated inflammatory markers in their blood work. Respiratory symptoms aren't always present. These cases are requiring pediatric intensive care, usually with involvement from cardiology and rheumatology and infectious disease. There is a case definition that's been developed for this syndrome. That's included on the slide. It would be any individual less than 21 years of age with a fever and laboratory evidence of inflammation. And you'll see the footnote there describes what the evidence of inflammation could include. So elevated C-reactive protein, erythrocyte sedimentation rates. I won't read through all of those, but it is included on the slide. And evidence of clinically severe illness requiring hospitalization with multi-system, so more than 2 organ involvement. So cardiac, renal, respiratory, blood, GI, skin, or neural. With no other diagnosis, these cases would also need to be positive for COVID-19 either by PCR or serology test, or have been exposed to COVID-19 in the 4 weeks prior to their onset of symptoms. So it's a pretty complicated case definition. I think our local public health partners are kind of used to case definitions being a bit complicated, but certainly this is what we're looking at as far as whether we're considering a case to be a multi-system inflammatory syndrome in children case. So many of you have heard that we have had 2 reported cases in Eastern Iowa. We're working through that information to determine whether they meet the case definition. We did issue over the weekend a mandatory reporting order for persons meeting these criteria, and it requires that those suspect cases be reported to the department through our normal 800 number within 3 days of case identification. So if you didn't get that, HUN, this information is going to be posted on our website, or should be posted on our website, and we would direct you to take a look there. So that's the information I wanted to share about that syndrome. Certainly, if you have questions, please reach out. You can enter those into the Q&A box or follow up with your field epi. I also want to go over a couple of other things that were included with that information that we sent out on Saturday. The State Hygienic Lab has expanded the testing criteria. So as we look at kind of reopening things, we want to broaden the PCR testing criteria, which would detect acute disease, as everyone knows, to include children who are receiving care in a child care home or a child care center, and the staff working in those centers if those individuals have fever or respiratory symptoms without alternative diagnosis. So that's included in the State Hygienic Lab testing criteria. We've also, which is an exciting development, included criteria for serology testing that's now available at State Hygienic Lab. So patients with suspected or confirmed COVID-19 infection who are more than 7 days post-symptom onset, people with an antibody response to serve as convalescent plasma donors can be tested, and also healthcare workers, essential service personnel, that's a broad list, critical infrastructure workers, that's the broad list that is included on the website, and then first responders. So again, those individuals can be tested using the serology that's available at the State Hygienic Lab as well. So if you haven't seen that updated testing framework, that is posted on our website, and I direct you there as well. Hopefully everyone saw in that communication that there is now a Test Iowa call center available. The numbers are included on the slide. The top number is the preferred number. And I should have taken this out. It was activated starting on Monday, so it's been up and running all week. On last week's call, webinar, we also had questions related to isolation guidance for serologic testing. This was updated in our procedure document, and I just want to go over it here as well. The first section of this slide is really related to the PCR isolation requirements. There's no change there, but where the discussion starts with note, persons who test positive for COVID-19 on serologic testing should not be excluded unless they also test positive for COVID-19 on PCR. And so, or if they're sick and have not yet met the isolation release guidance. So hopefully that's clear. Hopefully that helps. We heard from some of our health departments that were wanting us to put that guidance in writing. So we're hoping that that's meeting the need there. If not, let us know. We're happy to do whatever we need to do to make it as clear as possible. So I want to shift a little bit and talk about contact tracing. The CDC has recently issued guidance for contact tracing. And one component of this guidance is that there is a recommendation to contact cases within 24 hours of report to public health. So we're planning to continue 7 days a week contact tracing operations here at the state level. I'm not sure what the capability of daily contact tracing is for the counties that are doing their own contact tracing, but certainly we're available to help. If you need that assistance, just reach out through your field upbe as we've discussed on previous webinars. We're starting to look at kind of our plan for long-term sustainment of contact tracing operations. And in doing so, we're taking a look at this CDC guidance to make sure that we're doing it in accordance with the national guidelines. There's a couple of areas where we're going to need to incorporate some changes into our current guidance or current process to make sure we're in kind of accordance with the CDC guidance document, and that's related to testing of close contacts and definitions of close contacts. So we're going to be working on updating our procedures and also putting together a guidance document for next week. So be looking for that information. If you're interested in taking a look at that contact tracing guidance and haven't seen it already, I've included a link on the slide. So I'm sure that many of you are aware that the CMS, the Centers for Medicare and Medicaid Services, have put out guidance for long-term care facilities. We are in the process of working through that guidance in partnership with other state partners like Department of Inspections and Appeals, the Governor's Office, and also the long-term care associations. And so we anticipate having additional guidance related to how we want to implement that new CMS requirements and guidance documents in the coming days. So please stand by for that. Again, we're just in the process of having those discussions and working through the national guidance to develop an Iowa-specific approach. We are getting some repeat questions from our partners. The first ones are related to the Domo dashboard. And we know that with that being updated live now, and I'm sure you're all aware that it is now a live update, that things are fluid, things are going to change. Many of you know that we're getting a lot of duplicate lab reports, and so we're doing our best to catch those and work through them. Those should be caught at the point in which we're doing the contact tracing. For the counties that are doing their own contact tracing, you know that sometimes you catch those before we do, and so we just appreciate your patience. Please let your field upbe know when you have identified duplicates that need to be merged, and they'll work with Jill Newland, our IDES coordinator, to do that. I think everybody knows that it's really difficult when there's a misspelling in one of the lab reports, or if there's a hyphen that is included in one and not included in the other. We also have issues with date of births being different, and so sometimes we can catch those and sometimes we don't catch them right away, and so we appreciate your help and patience. Just let us know, we'll get those updated. The other thing we've gotten a lot of feedback on is people have commented to us that the long-term care data isn't current. Well, the data that dashboard is pulling from is IDES. And so that's why it's important to make sure that if there are new long-term care cases and residents and staff members, and this is a facility that is an outbreak, to make sure that we're tagging those cases in the outbreak field in the drop-down to make sure that they are posting appropriately to the Domo dashboard or the website dashboard. So again, we just appreciate your help with making sure those are tagged, and we'll continue to work with you if there's discrepancies there. We've also heard from quite a few people just questions related to how do I know if a test result is coming through Test Iowa. And so I think I've talked about this on previous webinars, but I just want to reiterate it because we're still getting questions. And when a test result is a Test Iowa result, you should see Test Iowa in the healthcare provider facility field in the event tab. So if you have questions, let your field epi know. But again, that's how you would identify a test result that comes through Test Iowa. All right, that is the crux of the information that I wanted to share from the start. So we've got plenty of time for question and answer, and we'll go ahead and turn to the questions now. Couple of comments that people could not hear me. I apologize if there are some technical issues. I haven't heard anything on my end about those issues, but again, this will be archived and available if people need to view it later. Yeah, there's a question here that really gets to the CDC guidance. The question is it a recommendation that a close contact of a positive case should not have a PCR test, just isolate themselves for the 10-3 rule? So I'm making the assumption this is a symptomatic close contact. So if there is a close contact who's symptomatic, this is exactly the piece of the CDC guidance that we're going to be incorporating into our guidance coming forth in the next few days. So CDC guidance does recommend that close contacts of positive cases be tested. And that's not something that we've pushed here in Iowa, and it's not something that CDC has previously pushed. This is a new recommendation. And so we want to just make sure that we're abiding by the national guidance as much as possible. And so I'd ask you to just stand by, and we'll have additional guidance out in the coming days related to this new CDC recommendation. Please talk about the new serology testing and how to go about submitting it. So I talked about that briefly. We have a new webinar system, so I'm not sure that I'm going to be able to do a very good job of switching to a live internet screen to be able to walk you through it. But if you go to the State Hygienic Labs main page, you'll see the testing for COVID-19 link. And in there is guidance. If you scroll down a little bit, the first guidance you'll see will be related to PCR testing. And then right below it is all the guidance that you'll need related to serology testing. So it's got the testing request form and the guidance for collecting specimens and all of those details. And so if you need something additional, please reach out to the State Hygienic Lab and they can talk you through it. A question about encouraging groups of 10 or fewer. That is still the recommendation, and we're still recommending social distancing. A question about, is there a separate investigation form for the MIS-C in IDES? And also a question about serology investigation forms. So serology investigation forms, the serology is an IDES, and you will be seeing, or you should be seeing, serology results from your counties come through the separate event name. So it's COVID-19 serology. So the forms in there, the forms are also posted on our website, I believe under the public health tab. So if you want to see the form, that is available there. As far as investigations for the multi-system inflammatory syndrome, we are doing a chart abstraction. The CDC hasn't put out guidance yet for what they want us to collect for those investigations. And so we're using some chart abstraction tools developed by other states. And so at this point, we're handling that on our end and working with our local partners to get a copy of the medical chart. So really, if there's a case in your county, we'd be asking you to help us connect with the infection control practitioner, if that connection's not already been made, and helping us get a copy of the medical chart. And we, I'm sure you all have seen, we do not anticipate releasing detailed information about the county of residence of these cases. I think it's really important to make sure we're not identifying these individuals. And so at this point, for the 2 suspect cases, we're just saying Eastern Iowa. Some questions about when can people have garage sales and other events. Honestly, all of those decisions are announced by the governor's office. And so if you're not watching those daily updates, we recommend that you consider having somebody just sit in on those. I don't have any information about garage sales. Another question about the definition of close contact, and that is the other piece of the CDC guidance that we're looking at this week. The CDC guidance says within 6 feet for 15 minutes. We've been using within 6 feet for 30 minutes. And so we're going to have some internal discussions with Dr. Padati and make a decision on which way we want to go there. We want to stick with the 30 or go to the 15. So please stand by for those. There's a question related to contact tracing in healthcare settings. So the CDC has really pulled back on their guidance for needing to do contact tracing in healthcare settings. I'd encourage you to take a look at the procedure document that's posted on our website under the long-term care tab. And that has the specific information from CDC saying that as long as proper PPE is being worn, contact tracing in healthcare settings is not necessarily warranted. We are starting to see businesses that require repeat testing prior to allowing employees to return to work. We've seen this with both positive and negative tests. Is there any guidance on this? So the CDC guidance for return to work or getting back to your somewhat normal activities is based on 2 things. The CDC does have the guidance that you can have 2 negative test results, or basically the 10-3 rule, as we call it, 10 days post-symptom onset, 3 days fever-free, improvement of other symptoms, or if the person's been asymptomatic, 10 days from the day that they were tested. And so to save laboratory resources, we've been just encouraging people to use the 10-3 rule or the 10 rule if the cases are asymptomatic. But certainly if facilities are asking patients to have 2 negative results, that is included in the CDC guidance. I'm a little confused by a facility requiring people to have negative, like to be retested after they test negative. I've not heard of that procedure, and that's not something I've seen in the federal guidance. And so if you're having questions or issues related to this and you would like some assistance, please reach out through your field epi. In addition, there is under the business tab on the website, partners and other agencies like OSHA, Iowa OSHA, and Workforce Development, and some of our other state agencies are answering questions when presented through there's a email address that's posted under that business tab. So certainly you can direct businesses to that resource if they're having questions, or if there's anything we can do to clarify what we're recommending from the public health slide, just give us a call. Yeah, so there's a question about testing guidance for long-term care facilities and assisted living facilities. And this testing question is really related to, it's going to be impacted by the most recent CMS guidance for long-term care facilities. And so, like I said, we're working with associations and other state partners in the governor's office to try to create a strategy for Iowa. And within that strategy will be guidance for testing of long-term care facilities and retesting. Certainly, we're aware that the CMS guidance has caused a lot of questions, and we're going to try and be as clear as possible in this guidance. A question about, do we want healthcare providers to report suspect multi-system inflammatory syndrome cases that they may have treated previously? Yes, we would appreciate reports of previous suspect cases. Questions about sleepover camps. And the thing I'll say about these kind of summer events is that we've been working closely with partner agencies that have regulatory authority over some of these summer events. And I think additional guidance is really forthcoming. I don't have anything to share right now related to sleepover camps, but that guidance is in development. Questions about whether cases in Iowa have been severely ill of the multi-system inflammatory syndrome. And at this point, our understanding is that the suspect cases are stable. It says, am I really the only attendee, or is it just not showing anyone? So I apologize again. We have a new webinar system that we've moved to. I'm felt like I was just getting good at the old one. So this is a whole new system for us to learn. And I'm not sure what you see on your end, but certainly you're not the only person on this webinar. So I think that was the question. A question about the rate of false positives and the serology testing and the level of immunity, since the level of immunity is not established. And I think that's a good question. And so we're still learning more about what the serology results mean and what level of immunity may be protective and how long lasting immunity may be. And so again, there's a lot of unanswered questions there as far as specific performance of the test. Again, that kind of goes in that bucket. This is, as you guys know, a whole new challenge for us, and there's a lot of things that we're learning as we move through this response. Some questions about, I think, the wording related to allowing healthcare workers and essential workers to be tested using the serology assay available at the state hygienic lab, and questions about how would it change what we're doing in the healthcare setting. So from the standpoint of the serology testing, again, that's a resource, that's a piece of information that we're just offering to partners in the healthcare workforce. I think it might help your healthcare facility kind of understand how the virus has already impacted employees and what potentially they could expect in the future. But again, as I just mentioned, there's a lot of unknowns here. We don't know if it's protective, and if it is protective, how long, those types of things. So I fully acknowledge that being able to know that you're serologically positive may not necessarily change what you do on a daily basis, but I do think it would bring value, certainly to the state level, to understand, and the local level to understand percent of population that's already potentially been infected with the virus. And from your facility level, it might help help your facility understand how this virus has impacted the workforce. If a healthcare worker has COVID symptoms, is it required that they get tested? What does the facility do if the people refuse? Again, I'm starting to see some questions come in that Shauna, our assistant in CADE, has been cutting and pasting from chats that go to her. If you can, please put your questions in the Q&A box. So again, if a healthcare worker has COVID-like symptoms, are they required to get testing? That's a facility decision. We're not requiring anybody to get testing. As far as what does a facility do if they refuse, we would recommend that the person be excluded in accordance with the 10-3 rule. So this is someone who's symptomatic. So before they come back, even if they've not been tested, if they have COVID-like symptoms, they should be excluded for 10 days from the date that those symptoms started and until they're fever-free for 3 days, and all other symptoms should have improved. Is there a requirement for retesting of asymptomatic healthcare workers that test positive prior to them returning to work? So we are not making that requirement. I've heard that some health facilities are requiring that people test negative before they return to work. The CDC guidance allows either the negative test or waiting the 10 days after the test was taken for asymptomatic people to return to work. So again, we're not requiring the negative tests, but some health facilities may be. If a healthcare worker does get tested and is COVID negative, do they still have to meet the 10-3 rule before they return to work? Only if they're symptomatic. So if someone's really got COVID symptoms and they're tested, even if they're negative, we would still recommend that they meet the 10-3 rule before returning. We have a question that's really a specific, a case-specific situation. So if about a case in coughing and locker room use, please reach out to your field EPI and they'll help you work through that. A comment from a local health partner that says, as we look at long-term contact tracing sustainment, would it be possible to get help if we need it without having to give it up entirely? That information we get through surveillance is essential in making logical decisions and coordinating care and logistics. So we certainly understand what you're saying, and for the logistics of us trying to take over cases, we did make a black and white distinction there. I understand the challenges that it causes you locally. We can try and have some additional discussions about lending some flexibility to that. No promises. We'll just talk through what that type of system may look like. So I understand and acknowledge that that policy is somewhat difficult. Question regarding healthcare providers qualifying to do serology testing. Do healthcare providers go to Test Iowa and take their assessment, or go to their primary healthcare provider? And so as far as serology testing, at this point, Test Iowa is not doing serology testing. So all of that testing, again, serology testing is available through many different reference labs. So if healthcare providers want to do serology testing, they certainly can for individuals outside of that criteria. But anyone meeting the criteria that I reviewed earlier in the presentation, they can be tested at the state hygienic lab, and their blood draw and the submission really needs to go through a healthcare entity, because Test Iowa is not set up to do serology testing at this time. Someone is wanting the CDC contact tracing link. I'll also ask our field EPIs to just send this out to everybody, just a link to this guidance, so that it's easier for you to access and you're not needing to try to pull it off the screen. Can we explain the difference between the serology test and the swab test? So the nasal pharyngeal swab, or the nasal swab we're doing in some situations, that's a PCR, it's a viral test, and that identifies acute illness or current illness. And the serology test, again, is an antibody test, the blood test, and that identifies a recent or previous infection. And so it's the serology test is really looking long term. Was someone likely already infected with COVID-19? Whereas the PCR test identifies a virus and indicates whether someone has a current infection and therefore could potentially be infectious with COVID-19. Someone looking for additional information on the serology testing. Again, that's on the State Hygienic Lab site. In the comment, it mentioned they're looking on our website. So I'd encourage you to go to the State Hygienic Lab website for that information. I'll see if our field EPIs can also send out the link to the State Hygienic Lab site when they send out the link to the CDC guidance. That link to the State Hygienic Lab site is included on the testing framework document that's on our website. It's also included in the HAN that I sent out on Saturday. Question on the IDPH site, is there guidance that serology does not trigger contact tracing? Yes, that's included in the procedure document that's posted under the local public health tab on our website. The governor okayed softball and baseball for the summer. When will guidance be presented for these activities? So the Department of Education will be joining, I think the governor announced this on today's webinar, we'll be joining the discussion tomorrow to discuss some of that guidance, and I assume that they'll be distributing the guidance for those activities shortly thereafter. Comment that people are having trouble finding the recorded webinars and that they have not all been posted on the HAN. Thank you for that feedback, and I'll double check and make sure that those get posted. A question or a comment, suggestion that a video explaining how to maximize all of the DOMO information would be helpful. Thanks for that feedback, and I'll check into whether we can make that happen. How do we put a close contact into IDES as an epi-linked case until they get tested? So, two things. If it's an asymptomatic epi-link, then they should be listed in the contacts tab within the IDES case. So there's one for household contacts, and then there's one for all other contacts. So asymptomatic people should be listed there. If they have symptoms, or if they've tested positive, they should be entered as a new case in IDES. So that's similar to what we do with other conditions in follow-up, but if you have questions, please reach out to your field EPI and we can walk you through it. Will the testing criteria be expanded to include PCR testing for symptomatic contacts? Yeah, so that's a great question, and that gets to what I was alluding to related to the contact tracing guidance from CDC. So as we look at trying to incorporate some of this guidance into a procedure document, it's also going to have a cascading effect on some other guidance and criteria. And so depending upon the way that we go there, there would likely be changes to other guidance documents as well, including testing criteria. So that's something that we're working on. So thanks for that comment. So if a close contact tests negative, and after the positive is released, the close contact experiences symptoms on day 10. I'm struggling to follow this, so if you wouldn't mind, please reach out to your field up and they can help kind of walk you through it. Do some state health departments have recommendations for COVID-19 patients needing 2 negative test results before going back to work? I'm going to be honest that I haven't taken a look at all the different state health departments' recommendations. We've been really just focusing on CDC's and in our recommendations, so I'm not aware one way or another whether other states require 2 negative tests before returning to work. Certainly, maybe they do, but I've not heard that. But I've also not specifically gotten to look at that. If a patient tests negative by PCR, is it okay to release the person back to normal activities when their symptoms resolve? No, we would still recommend that they follow the 10-3 rule. So they should be 10 days out and 3 days fever-free. Some more questions about positive serologies. Again, from an individual level, there's, again, still a lot we don't know related to how protective is a positive result, how long lasting could immunity be, those types of things. So it fully acknowledge that there's a lot of unanswered questions. From the standpoint of the value, again, it's valuable to know kind of to public health locally and at the state level to public health to understand how our populations have potentially already been impacted with this virus and what we could be seeing in the future. And so that is important information from a public health perspective, also for a workforce situation like I previously talked about. Question about expectations on the holiday weekend. I know that this is a long haul. This is kind of an unending journey, as I think what I mentioned to some of our local public health partners earlier today. We totally understand that you may be dealing with fatigue in your workers. We're dealing with that at the state level as well. So we appreciate everything that everyone's doing. I will say from the state perspective, we are going to have our call center up and going throughout the weekend, including on Monday. And so that's our plan. So if you need us, just call the normal CADE number and we're available to help you do whatever you need to do. Question about, we're beginning to instruct classes. We've limited the number to 10. Is this acceptable? So gatherings of 10 or less is still the recommendation. Get a couple of questions about proper PPE for long-term care centers. And no, a PAPR is not required. A face shield, a mask, or goggles or a face shield, mask, gown, gloves are considered proper PPE for a long-term care center. If you're doing an aerosol generating procedure, then an N95 should be worn. This individual is referring to a PAPR. If it's an aerosol generating procedure, then you could wear a PAPR if you would like. If you don't have N95s available, either one is fine. A lot of questions about this negative testing. I think we've covered that, so I'm going to skip through some of these. A question about, can we create a form on the PCR investigation form on our website that can be used to like write in the answers to the investigation? The comment is that everything on the current form is kind of on a single line. There's not enough space to write, and we'll work on that. Appreciate that. When we do get that done, we'll just post it back to the web page where the other form is. We'll just replace it. More questions about businesses requiring 2 negative tests. So it sounds like there's a lot of businesses that are requiring that. Again, certainly the CDC guidance allows that. And there's a document on our website under the, I think, general public tab. It's called what to do if I get sick. And at the bottom of that, it talks about the 2 options for returning to normal activities. So if you have questions about the 2 negative test approach, it is listed there. I'm sorry, I wish I could share the screen and walk you through how to get there. If you have questions about the accuracy of the serology test, we've seen that a couple of times, I would go ahead and reach out to the State Hygienic Lab if you have really lab-specific questions. I think some of these are coming from laboratory partners, and I think it'd be best to talk lab to lab. If the dashboard shows positive serology cases in our county, how do we find these in IDES? So again, I'd encourage you to take a look at that procedure document. It's posted under local public health. But as far as how those cases are listed in IDES, the 2019 novel coronavirus events, those are PCR results. COVID-19 serology are obviously serology results. And so you would find those under the COVID-19 serology. And you should be getting alerts on that. But as we talked about last week, we've been hearing from some counties that maybe aren't necessarily getting all of the alerts, and we're trying to work through that. But the workaround there is to just run a batch report. And in last week's webinar, we did walk through how to run that batch report. I apologize. I wish I could pull up those slides quickly here, but certainly take a look at last week's, and you should be able to do a batch report to specifically look at serology cases. If you need any help with that, just reach out to your field epi. Can local public health agencies draw the serology on healthcare workers and send it to SHL if they want to? Certainly, if you want to order that testing under your local public health medical director and work with your healthcare facilities to do blood draws and submit those specimens for serology testing to SHL, you can absolutely do that. A question about, are children with multi-system inflammatory syndrome, do they test positive for COVID? And that is included. The testing positive or having contact with a positive case is included in the case definition. I'm moving the slides back there. And so the third criteria here is positive for current or recent infection by PCR serology or exposure within 4 weeks prior to onset of symptoms. So that's the case definition. So if a healthcare worker, should a healthcare worker be excluded even if they test negative? Only if they're symptomatic, then we would recommend that they be excluded. So comment, so now we're back to contacting the cases every day. I think that comment is related to the CDC guidance for contact tracing. And so the recommendation in that guidance document is that you contact a case within 24 hours of receiving the positive result. And so that's the recommendation. It's not related to recontacting cases every day. It's just making that initial contact, initiating the investigation within 24 hours of receiving the report. So yeah, please do not construe that to mean that you need to call cases every day. If you have any questions, reach out to your field epi. I'm sure the field epis that are listening to me continue to say that or appreciate all those calls. No, seriously, they're there to help you. We want to provide sound information to you, so don't hesitate to give us a call. Anything new on guidance for travel? So also in that procedure document, we articulated that we are no longer recommending that people who travel out of Iowa but within the U.S. self-isolate for 14 days. So that is no longer a recommendation. But CDC does still recommend that people who travel internationally self-isolate for 14 days. So that is a recommendation that's still in place. But out of Iowa but within the U.S. travel, there doesn't need to be a 14-day isolation period for that, unless someone obviously has symptoms or unless they had close contact with a confirmed case. But those are the same things that we would recommend for people who have those types of contact or illness here in Iowa. Our pathologist is hesitant to do serology. How accurate are the results from SHL? Again, there's a lot we don't know about that test. Certainly, if your pathologist has questions, we recommend that they connect directly to SHL. Will the case investigation for the multi-system inflammatory syndrome be done at the local county basis? At this point, we're working with our local partners where cases have been identified to get access to the medical chart, but we're doing the chart abstraction. I think in the coming days, we'll know more about what CDC is asking local health departments and state health departments to do with these types of reports. But at this time, no, we're not asking that you do anything. We would have a lot more positive cases if people weren't worried about the costs associated with a doctor's visit. Test Iowa sites are not close or feasible for rural Iowans to drive to. What's your guidance? I want our numbers to reflect accurately what's happening in our communities. I think that that's valuable information. Certainly, there's been some additional kind of pop-up Test Iowa sites. I would recommend that you talk with your emergency manager and enter any testing requests into WebEOC. So if you are interested in having some community-wide testing events, please enter those into WebEOC, and your emergency manager can do that. And we can try and do everything we can to work with you to promote testing in your community. If a healthcare provider tests positive on serology, are they considered infectious? No. So I touched on the serology guidance earlier. So people who are positive on serology alone do not need to be excluded, regardless of their occupation. The only time that they potentially would need to be excluded is if they're also PCR positive or haven't met the 10-3 rule previously. But someone who's asymptomatic, who was only tested via serology, not tested via PCR, and was serologically positive, there's no exclusion recommended there. What is the best way to find daily new negative counts, death counts, daily positive counts. Sometimes they're in a press release, but the information isn't always on the IDPH website. So if you go to the coronavirus.iowa.gov site, that's where all of the dashboard information is posted, and you should be able to access all of that new information, or all of the information you included in your comment is available on the website there. A lot of questions about what should we be giving our county fair boards for guidance. And so I think there's some other questions about other types of situations, and all of these decisions are really being driven with the governor's overview or oversight. And so I have not seen county fair board or county fair recommendations. So again, that's something that I would just continue to look for. I understand that those fair boards are wanting to make decisions. I'll reach out to our partners and see if there's a process or a thought of when additional guidance may be available. A question about, will we get some time to prepare if the PPE order is going to change? For example, if we can no longer use expired N95s or non-fit tested N95s, or the supply chain is disrupted, how much lead time will we have to prepare? I can just say that we'll make you aware of those things as soon as we're aware of those things. I don't think that there's any imminent changes that I've heard of, but certainly we'll do our best to give you as much lead time as we can. Can the isolation guidance document be updated on the IDPH website to read 10 days, as we have multiple community persons disputing the 7-day versus 10-day education? I believe that all of that documentation has been updated on the website. If you're seeing something, that's discrepant, please reach out to your field epi, but we're linking directly to the CDC document that says what to do if you're ill, that talks about the 10 days and 3 days fever free. So that should be updated on the website, but if you're seeing something, let us know. A question about, can we get those numbers one more time? I'm not sure which numbers, maybe those numbers. So I just changed it to the call center slide. I think maybe that's what you're asking about. So will contact tracing for cases of multi-system inflammatory syndrome be done by local public health or state? So in these situations, again, we'll be working closely with local public health, and so we can just coordinate that as those cases are identified. Do we still screen visitors and patients coming into our facilities based on travel? So certainly the screening criteria that a health facility uses, that's obviously your decision, but from our perspective, we are not recommending that people who have traveled out of Iowa but still within the US be needing to self-isolate, so we'll be doing anything different. And the business guidance that we have on our website is based on fever and symptoms. All right, I have 1 o'clock, so I'm gonna kind of cut off. I think that most of what's left is things that we have kind of touched on. There's one, it's extremely difficult to use IDES reports to review cases due to the majority of cases still being status as pending. Is there a timeline for negative cases to be closed as not a case, or for different tools to be available in IDES. So I think there's a couple of things in there. So we have our IDES programmer, Jeff Overson, has created a query that closes negative results. So those should be closed in the system. If you're finding some that are not closed, certainly feel free, if you are an IDES user and familiar with the process, to mark those as not a case and close them out. Or you can reach out to your field epi and they can help make sure that happens as well. As far as the majority of cases, still status is pending. So part of that pending may be due to the fact that we're leaving cases open until we do the 10-day check-in to make sure that the person has recovered. So that might be part of it. If you have specific questions or concerns, please reach out to your field epi. So at this point, we've hit the 1 hour mark. I just want to thank everybody for your time and for joining today and everything that you're doing to respond to this pandemic. We greatly appreciate your partnership and appreciate everything that everyone's doing throughout the state. So have a good rest of your afternoon, and we'll have another webinar next week.